good morning, Colm, and welcome to UEG Week 2018, and huge congratulations on your Lifetime Achievement Award. Can I start by asking you, what does this award mean to you personally?
Well, thank you very much for your congratulations, but it is certainly an honour and a distinction, and I do consider it to be the pinnacle of my career.
And what's driven you to succeed and sort of get to this point where you are being given accolades for your career?
Well, my career, of course, spans back a long time now, but I was always intrigued by the unmet need of patients that I met in a gastroenterology outpatients. And I always knew there must be some answers, so I think I always had an inquiring mind that wanted to improve their lot, and particularly their health, in a positive way, not always to consider disease, but consider the positivity of being well. And every patient I saw in the outpatients, always there was something missing for them. I always thought that we could do better. And that started in those days in the 80s, where we were mainly seeing patients with peptic ulcer disease, a lot of them. And we did have good medication for them, but the difficulty was that they needed to take that medicine for the rest of their lives to keep them well. And if they stopped taking them, their ulcers would relapse. And then by chance I came across, not by chance, but it was published in 1983, the seminal paper of Warren and Marshall showing that Helicobacter pylori caused the gastritis. Now, what always intrigued me about ulcers is the amount of pain they suffered. And when you looked at an ulcer endoscopically, it's quite small. It looks like a cold sore. But this cold sore would wake them up in the middle of the night. They would be miserable. They had to go down and drink gallons of milk to try and neutralize that acid. So, although what we knew at the time is that if we could suppress acid, that we could keep that ulcer at bay. But what was happening once they stopped the tablets, the acid returned, the ulcer returned. But what was driving that was this Helicobacter that Warren and Marshall first described. The other difficulty I had was that we saw so many patients. We would see up to 80 patients in an outpatients, and most of them would have ulcers. And this volume, of course, we played to that strength so that we could make observations in one hospital, that we could, and it was sort of amateurish in some way, randomize patients to the current treatment, which was acid-lowering agents, or bismuth, which turned out to be known to have some antibacterial effects. Those patients who got the bismuth did very well when we followed them up over a year. And those patients who got the acid-lowering agent, all of them had the ulcer back. What was difficult to do is to convince patients to come back for an endoscopy, when they're totally well, to prove that their ulcer was healed. And we had to even call around to their house to convince them to come. The registrar at the time, when they knocked at the door, they thought it was the milkman because their consumption of milk had reduced so dramatically they were looking for arrears. But we convinced them to come back, and it turned out why they were so well is they had got rid of the bacteria. But that was only a single agent. So from then on, we realized that we need to use more than one agent to get rid of this bacteria. And even to the present day, we have to use 3 different drugs, at least 2 antibiotics, and an acid-lowering agent, or perhaps bismuth, which is making a return. But once you cure them of the bacteria, eradicate the bacteria, you cure the ulcer. The other chronic disease that we saw at the time, if you want to call it chronic, I don't like the term chronic because that gives them a certain label, is inflammatory bowel disease. And this affects young people. And that really did impress me, that some of these patients, in fact, died as a complication of the disease, that they had multiple operations and fistulating disease, terrible symptoms of passing feces in their urine or through their skin. It was dreadful. And to think that we certainly could improve their treatment. And I think the best way of improving their symptoms would be to diagnose them early. There's quite often a delay, especially in young people, thinking, passing off their symptoms as maybe stress, because at that particular age, stress does play a role. They're maybe preparing for exams, financial worries, interpersonal worries, and so on. And they would stave off going to see a doctor. And then what would happen, and still happens, they present acutely as an emergency to A&E, an accident emergency department. An accident emergency department is not a pleasant place to be ending up in, because all besides them suffering, there are other sufferers there, and maybe patients who shouldn't be there in the first place. Drugs and alcohol play a big role in patients presenting to A&E. So can we do better? Can we pick them up earlier and institute treatments sooner? And I think the treatments have evolved, that we have now much more effective treatment than we had in the 80s. In the 90s, we saw the introduction of these biological drugs, which have, I think, altered the whole disease process. But as we all know, we still don't know the cause of this disease, and I think that's a constant challenge. So there's many challenges left for us. The other major area that I was involved in is positive health in preventing cancer, colorectal cancer in particular. The evidence is there that this cancer can be prevented in the most cost-effective way, superior to other screening programs such as breast and cervical. And I don't like arguing about our disease is better than others. Any disease prevention is better than none. Colorectal cancer screening has been slow to get off because, of course, the symptoms are embarrassing. You know, that nobody wants to talk about these in public, collecting bowel motions. It's unpleasant, and the patients are individuals. You were talking about healthy individuals, are a bit reluctant to engage. Colorectal cancer affects both sexes, so that we don't have a lobby, a strong lobby, because like prostate cancer affects men, and breast cancer, of course, females, so that they have a stronger lobby for those two diseases where we span both sexes. But colorectal cancer is common. You know, in Ireland, a small country, we have 2,000 cases a year, 1,000 deaths. And if we had a screening program, we think we could reduce that significantly down to a third. We won't prevent it totally, and I think that's another point that should be made about screening. We won't eliminate the cancer totally, but we certainly reduce the incidence and mortality. So that efforts should be made that the public be aware of these symptoms if they have symptoms, but beware they can also benefit from being part of a screening program. The success of these screening programs depends on the uptake. If you have a slow uptake, it's a waste of resources. If you have a high uptake, the success improves by the amount of participation. So there were the three areas of research that I've been involved in. I'm still passionate about, because in each of those areas we still can improve. Mm-hmm. We mentioned about Helicobacter. Well, that's moved on now to gastric cancer and gastric cancer prevention. Thankfully, gastric cancer isn't such a big problem in Western Europe as it is in other parts of the world. But within Europe, there is pockets where there's a high incidence in the Baltic states, and for some reason in Portugal they have a higher incidence, maybe threefold commoner than in Northern Europe. And again, we think the reason is that they have a higher instance of this Helicobacter pylori infection. In the Asia Pacific, where they have a threefold increase in gastric cancer than what we have, they are well on the way of doing screening programs for the whole population in preventing gastric cancer. I think if we prevent any cancer, during my professional career, when I had to break the bad news that the patient had cancer, never pleasant, either for the patient and for the person or the doctor who has to give the news. They always ask, could I have done something different? Well, I think in terms of gastric and colon cancer, we can. You should get your family to be screened at least. And if we get that message across, I think we would achieve a much more positive health that I started off talking about.
Mm-hmm. Fascinating. And what would you say is your sort of greatest achievement in digestive health during your career?
Well, I think that it's a recognized now specialty. I think that it's evolved during the last 50 years with technology. Endoscopy has improved hugely. No, not thanks to me, but just to technology in general. The improvements are enormous. When you look back, it's just not comparable what we're looking at. Images we're looking at 20, 30 years that we can see now. In terms of treatment, we've seen huge improvements in treatment. The specialty is now recognized as a major player, that it's ranking with cardiology, respiratory and diabetes. I think it's within hospitals, I think management recognized that it does play a major role. In terms of referrals, what struck me is that the number of referrals to gastroenterology is greater than the other specialties. Now, again, it's not worth fighting between specialties, because we are all looking after a person. They don't know what disease they have, and they want to get the best of care. So I think if we, first of all, try and get a bigger budget for health and keep people in positive health, keeps them working, they don't miss work, they make a positive contribution to the social fabric of the country, that we will have achieved that. I feel that we do have to fight, and I don't like using the word fight, but we have to explain to management and to politicians the importance of investment in health research, and particularly the one that's under invested is translational medicine, what we do every day. Politicians and management think the investment should be all in basic research. Yes, that's a good investment, but I think that from the bed to the bench is well worthwhile. At the coalface, I think underfunded and underappreciated, because they think that other people will take care of it, that such as charities, pay individuals themselves. But I do think there should be central funding for these efforts.
And is there anything that you'd say that you've not achieved in your career so far, that if you were given the opportunity you would like to achieve in the future?
Well, of course, I'd like to see the cause of these diseases. What we're seeing at the moment is reducing inflammation. I'm talking about inflammatory bowel disease. It would be great to see if we could find a cause, like we did for peptic ulcer disease caused by Helicobacter. If we could find a specific agent for inflammatory bowel disease, I think that would be a great step forward.
Mm-hmm. Thank you very much, Colm, and again, huge congratulations.
Thank you.